Here is Dr. Anureet KAUR. Yeah, please.
Good morning, one and all. I'll be presenting a case series on orbital dermoid with discharging fistula. So we all know that dermoids can either be superficial or deep. Superficial dermoids are diagnosed early. However, deeper dermoids are inconspicuous in nature and they lead to misdiagnosis and usually are detected late. So if deep dermoids remain dormant normally, so when do they actually present? In case of trauma or infection, there is rupture of the cyst which forms a tract and the tract epithelializes and there is a formation of permanent fistula. So our study was a retrospective observational study carried from 2019 to 2022 and patients with orbital dermoid along with fistula were recruited and they were studied for presenting features, management and treatment outcomes. The average age was 18.4 years. With out of total 28 orbital dermoid patients, 5 of them presented with fistula, accounting for 17.8%. Out of them, 60% were male and had right eye as the most involved eye. Duration of symptoms ranged from 1.5 weeks to 8 years, with 8 years being the most chronic one. And treatment was, orbitotomy was done for all the patients with complete removal of fistula. We even used trypan blue as an adjunct for identifying the fistula and removing them completely. The mean follow-up period was 2 years and no recurrence was noted. So I'll be presenting the cases. So case number 1 was misdiagnosed previously as congenital nasolacrimal duct obstruction. These pictures were taken by the father and the pictures show puckering near the lateral canthal of the eye. And this patient was previously misdiagnosed as CNLDO and when she came to us, we did imaging and finally it was a dermoid with fistula and she was treated successfully. A 30-year-old female, she had a previous episode of redness, discharging fistula and swelling. Similar episode happened 12 years back. She was diagnosed as tubercular granuloma and even received ATT. When she presented to us, on table we used trypan blue as an adjunct to basically delineate the epithelial lining of the fistula so that complete removal could be done. This is the post-operative picture of the patient with no recurrence. A 14-year-old male presented with pus discharge on lateral side of the right eye for 8 years. So he presented with multiple previous surgeries done elsewhere and he was suspected to be a cholesteatoma case. Intraoperatively, we went ahead with the orbitotomy and the fistula was basically intraosseous and it was extending till the zygomatic arch. So there was we did complete removal of the orbital dermoid along with the fistula. There were 2 fistular openings which were noted. One was near the lateral canthus and one was a bit superior to it. So we used Bowman's probe to delineate the fistula and both the fistula were completely removed. This is the post-operative picture of the patient. This is another case with multiple fistular opening, one near the lateral canthus and one near the brow that we can see, and we removed it completely with no recurrence noted. So on review of literature, there have been cases where orbital deep dermoids have been, they were so lately diagnosed that they even led to chronic osteomyelitis and few of the cases have been reported as meningitis. One of the patient, one case report from Nigeria showed that because of lack of care, after 2 years, the child had to undergo exentration. So our study is basically considerably the largest case series in Indian subcontinent. We used adjuncts like trypan blue and glue was also used, cyanoacrylate glue, and it led to complete removal. Therefore, there were no recurrences. So in conclusion, if there is chronic periocular cicatricial process, if we see any teething, any fistula, any retraction, we have to rule out underlying dermoid. In case of isolated discharging fistula, it can be a tip of the iceberg and we have to evaluate all the cases radiologically. Complete excision of cyst and fistula is of paramount importance and we can use adjunctives like trypan blue and cyanoacrylate glue. Thank you.
It's a good presentation, but I would like to ask you some questions. How do you differentiate between congenital nasolacrimal duct obstruction and this fistula?
Ma'am, basically this was referred from outside. So this patient for around 2-3 months Previously, it was diagnosed as congenital because they were presenting with swelling and discharging, like pus discharge was there. Also, this child had another opening in cul-de-sac also. So they were thinking that this is CNLDO, but once they presented, we did radiological imaging, and it was actually a dermoid was sitting there.
No, no. What radiological imaging you have done?
Ma'am, CT. CT.
Only CT.
CT.
Have you tried syringing in this case?
Ma'am, syringing was tried. That was normal. Like patient underwent syringing and probing. That was normal.
Okay.
Yeah.
Then any other contrast studies you have done?
Counter study.
No. Is there and the third, I think third case, gyrgoma, is there any intercranial extension was there?
No, ma'am. No.
No. Okay. Okay.
Thank you.
Okay, thank you.